Welcome to Progenesis Academy webinar, session 37. Today's topic is fertility options after 42. In this webinar, we will focus more on advanced maternal age, and we will have our panel answer some of the questions live for patients who have questions. Let me introduce our fertility panel. We have two great physicians that are specialized in fertility treatments. We have Dr. Smikle, Medical Director at Laurel Fertility, and Dr. Deng, Fertility Specialist at Stanford Fertility University. Thank you so much for joining us.
Thank you for inviting us.
Thank you so much for having us.
Thank you. So my first question is about, defining the importance of age and its impacts on fertility. So most of the times when you're, looking into patients, age play a major role. Can you guys explain to us why is it important? Why age is so important when it comes to treating fertility patients? And I'll go with you, Dr. Deng, first.
Yeah, we already know women are born with a certain number of eggs on the ovaries. And this number of eggs will not we're not able to produce new eggs. And the number of eggs as well as the quality of eggs will decrease over time. And around age 35, we know roughly 40 to 50% of eggs will have abnormal chromosomes. And around age 38 to 39, that a percentage of abnormal chromosome X might increase to 70% or even 80%. And the majority of these eggs that carry abnormal chromosome after fertilization and form the embryo, these embryos carry abnormal chromosomes. Most of them cannot make a woman pregnant. And even if they can result in a pregnancy, majority of them will end up with miscarriage. Only a few types, for example, trisomy 21, 18, 13, those can end up with a live fetus or live birth. So that's the reason when women is getting more advanced age or getting older, not only the number of the eggs available is decreasing, but also the quality of the eggs is decreasing as well. So that's the reason you see a woman who's over age 38 or 40, it's hard for them to get pregnant, and there's a higher chance of miscarriage after natural pregnancy.
Thank you so much. Dr. Smikle?
I think that's actually the important thing to kind of emphasize is just that with having only a limited number of eggs and then having things that you do through life that may influence that, there are going to be things that are going to make things worse, if you will, over time. And that doing things to improve the eggs, there's not a whole lot we know that's going to be there. So the important thing is to realize this thing that Dr. Deng had actually mentioned in terms of trying to select out the best embryos that's created, because that's not something that we can change. Each month when a woman ovulates, if she does ovulate, the quality of the eggs may diminish. So therefore, it's going to take a longer time to conceive as she gets older, and the chances in terms of miscarrying are going to be higher. So then you have to start taking measures to kind of improve that, and that's the thing that we're going to talk about today.
Very good. Thank you so much. I think we should start getting some questions live to get most of these patients' questions answered. Riley, do we have a patient online?
Yes, we do. Hi there.
Hello, can you hear me?
Hello, thank you so much for coming into our program. Please proceed with your question.
Yes, I am a 45-year-old African-American female. I have a history of having 2 IVF cycles. Me and my fiance, we've been through 2 cycles together. I currently take iron pills. I take a vitamin D, a woman's 1-a-day vitamin as well. I just had a small fibroid removed and a little bit of endometriosis was found. So that was removed as well. And recently, in January. And we're in the process of seeking a donor so that we could do IVF that way. And my question is, I'm also 45 and my BMI is a little high. It's 37. But with my past history, we just want to know what diet or exercise you would recommend to me.
Thank you so much. Dr. Smikle?
Well, that jumps to quite a bit in terms of addressing some of the concerns that arise when women are older. So you're going through and you're choosing an appropriate option that's going to give you a wonderful opportunity, because then you're using eggs from a younger woman that is going to give you a much, much better chance. I think what you described in putting it into a nutshell is that you're doing things to maintain at least the best profile you can in terms of your own health and well-being. You've done things to address what's going on inside the uterus to kind of make your host, the cavity, as hospitable as possible. So that's going to be important. And therefore, there's not a whole lot that you can actually do from a specific diet standpoint that is going to basically have that much of an impact, unless you're one person who goes overboard in terms of either eating unhealthily to begin with. And that's not what I'm hearing you describe. I do think it's important to make sure that you're going to find a program that's going to basically talk to you about some of the different influences that simply being African American may have on your chance for success, because it does take some understanding, if you will, or nurturing in terms of improving that opportunity, because some women will end up having some challenges. So that's important to know. I'm not saying you will, I'm just basically saying that's a thing you have to address. Using donor egg is going to be the best place to start, so therefore that'll actually improve your opportunity overall. But other than that, I think you're doing all the right things in terms of trying to improve that opportunity by doing what you're doing now.
Thank you.
Thank you. Any other question?
What would be your recommendation? We're considering a fresh egg versus a frozen. What are your thoughts on that?
Okay, before we take the before we take that question, let me let Dr. Deng give her opinion on this topic, and then we will go to that question. Dr. Deng?
Okay, yeah, all right. Thank you for providing all these your medical information. I agree with Dr. Smikle. I don't think there's scientific evidence that would support any one particular food, diet, herb, or supplement will significantly improve the fertility in healthy women. However, I would say there's a good data to support the dietary or lifestyle exercise change for women who's significantly has overweight or high BMI. So I think whatever you can do to maintain or try to optimize the BMI and maintain a healthy weight through a healthy eating, regular exercise, that will significantly be beneficial. I think if you, I think you're on the right track. You asked the question, you must did a lot of research. If you ideally you can lose some certain number of weight, and through we say, when we say healthy diet, means any diet similar to the Mediterranean diet, low carb, and eat a complex carb, a whole grain, more vegetable, high fiber, plant-based protein. I think those will be helpful. And also a moderate aerobic exercise, exercise at least 30 minutes to an hour a day. If you can do 3 to 5 times a week, I think that will help as well.
Thank you so much. Thank you so much. Let's take the second question, which is fresh versus frozen eggs. What is your inputs on this, Dr. Smikle?
The question probably more relates to thinking about how many children you're planning for. There's a good deal of data now that suggests that getting good quality eggs within a frozen cohort will give you a really good opportunity in terms of getting pregnant. So I'm not sure you may need to consider using a fresh donor unless there's something specific that that you're looking to. One thing I know is just that having donor eggs from an African American donor is one thing that may be harder, and that may be one thing that's leading you to the decision. But also, if you're thinking about having more than one child, that's another opportunity where you might consider using a fresh donor. However, if you only want one child, it may be worthwhile to simply choose to use a frozen donor eggs if you can find a donor who's available.
Thank you so much. Dr. Deng?
Yeah, I agree. I think like you consider like what's your goal like of your family in terms of size of your family, how many children you want. Choose a frozen donor egg from the frozen bank probably will save you a lot of time and energy in terms of like you have to look for through an agency, a lot of logistic issues you have to deal with. You can get it probably sooner instead of like looking for a fresh donor or direct donor. But if you want to have a 2 or 3 or more children, then fresh donor probably is the right way to go because the surplus embryos will provide you basically it will probably be more cost effective, let's say in that way. For frozen donor, usually they provide 5 to 6 eggs in each batch. And I would say 80% of women will probably get only 1 blastocyst at the end. And the 20% will get like a 2 or more embryos available for transfer from that 1 batch of frozen egg.
And in terms of success rates, is there any difference? Dr. Smikle or you, Dr. Deng?
I don't think there's actually much difference between the two if you're selecting from a good donor, because I think that's actually what's going to dictate the success overall. If you're getting a good group of, a good cohort of eggs from a donor, especially a donor that's been proven successful before, then you're going to have a great chance of success. Typically, in getting that 5 to 8 set of eggs in that cohort, most programs are actually talking about at least a 50 to 60% chance for success in terms of a transfer. So that's fairly good.
Yeah, thank you so much. Dr. Deng, would you agree?
Yeah, I agree.
Perfect. Any other question before we move to the next patient?
No, I appreciate your feedback and thank you. And y'all gave me wonderful suggestions and we'll use them. Thank you.
Thank you so much and we wish you good luck. Let's go to the next patients. Hello?
Hi.
Hi, how are you doing?
I'm good, thank you. Thanks for the opportunity.
Thank you. Please proceed with your question.
I am a 42-year-old and I live a fairly healthy life. I exercise, I never smoked in my life and I rarely drink, although I have a glass of wine right now. It's just, here and there. I have a 7-year-old son. I was 35 when I gave birth to him and we didn't have any issues, but the second one, when we start trying, it became very difficult. We had 3 IVFs. I had 3 rounds of IVFs and in total I had 36 embryos, but unfortunately, none of the embryos was normal. So my doctor suggested that we consider donor eggs and we are considering it. But he also said that my husband should get tested for DNA fragmentation. I don't know whether we will get anything from that, but I guess my question is, before we start thinking about donor eggs, is there anything we should think about? I guess the answer is no, but I'm still curious. And related to that, if we do end up using a donor egg, I do have a slight preference for gender. It's not major, but I'm thinking about, again, having the embryos tested genetically. I was wondering what the doctors have, if they have anything to say about that. Also, whether they know any resources that we can use to prepare us both physically and emotionally for using a donor egg. So those are my questions. Thank you so much.
Thank you so much. Dr. Deng, would you like to answer that question?
Yeah, first of all, thank you for sharing this information. I would say if you had 3 IVF cycles, you get like 36 embryos. That's an amazing number based on your age. Your ovarian reserve, I would say, is better than probably 95, 97% of women who's at age 42. That being said, we might want to look for some other potential, I would say, medical conditions. For example, do you have PCOS or not? Or other reasons that could potentially to make you have a lot of follicles on your ovary. I think donor egg is typically reserved as a last resort for most women. If possible, you still, I think most women still want to use their own eggs to have their genetically linked child or children. But I would say if you are ready to use a donor egg, I think a donor egg will still a great option. It will provide a good prognosis and a good pregnancy rate. But if you have a good ovarian reserve, you're still considering to try another cycle, I think potentially you can do some more testing, for example, your testosterone level, or make sure your thyroid function is normal. I don't know how often you get your menses, any potential like a PCOS diagnosis when you were young. But I would say with this 36 embryos available after 3 IVF cycles, and you did not get any good like embryo, there's something I think like assessment could be done potentially. And also you mentioned like your partner's sperm. I think DNA fragmentation is something that can be assessed as well. And I don't know what's the fertilization rate, and the 36 embryos, you might have like a more oocyte retrieved than this number. And I assume there's a good fertility rate. Otherwise you want to get like so many embryos. But the DNA fragmentation test, if it's very highly abnormal, then antioxidant supplement is what your partner can use. And there's some data actually suggesting like a TESI sample might have a better outcome compared with like ejaculated sample, although the data is still not that solid. But I just personally, I feel you have a good ovarian reserve, and there's still a hope, and maybe some like assessments can be done before you decide to use a donor egg. But if you want to use a donor egg, that's completely reasonable, and that's a good option as well.
Thank you so much. Dr. Smikle?
I would agree that, from what you're describing, to create that many embryos, and I would imagine you're also talking about embryos that may potentially be biopsied, that's a significant number. So unfortunately, you're just simply dealing with statistics. As we talked about earlier, as you get older, the number of abnormal eggs are going to increase. There's a lot more information to say that you may end up having challenges in terms of spindle formation and also the meiosis that causes these fragmentations as you get older. So therefore, a lot of the factors that Dr. Deng was talking about, anything that's going to improve the dynamic within the egg itself may improve your outcome. And therefore, it gives you that potential to at least try, having your own child. Egg donation is always going to remain an opportunity for you to use, and that's an important thing for you to realize, simply because you can go through and you can exhaust anything on your own before doing that. Still, if the one thing you pointed to was basically considering some sort of family balancing, and before we talked about using frozen donor eggs as an opportunity to get pregnant, it's not as likely to work if you're thinking about using genetic testing for the embryo, simply because you're just not going to get as many embryos, unless you're going to end up having a larger cohort of those frozen donor eggs, or considering using a fresh donor. So, as Dr. Deng said, exploring everything on your own, using your own biology first, and then moving on to donor eggs is definitely an opportunity. But either way, you should actually have a great opportunity in terms of parenting again. And then that's important to realize.
Very good. Thank you so much for your question. Do you have any other question?
Thank you so much. Very nice to meet you all.
Thank you.
You're welcome.
We wish you good luck in your IVF journey.
I Right.
Very good. So we have a patient that is asking on the chat, and her question is, what is the chance of transferring an abnormal embryo that will autocorrect later on? Is that a possibility? And I'll start with you this time, Dr. Smikle.
That's a lot of information that's actually coming about now, and there's a lot of questions patients are asking, because there are some reports. Norman Gleicher published a report that transferring a high number of abnormal embryos, there is still a pregnancy rate because embryos can autocorrect. The important thing to realize, though, when we're talking about pregnancy rates, we're egoists, we're scientists, so we're always trying to transfer the normal euploid embryos first. And we know what that implantation rate should be. Typically, in a genetically normal euploid embryo with good structural characteristics for the embryo, the implantation rate is going to be upwards of 60 or 80%, depending on the program you're in. The same equivalent embryo that's going to be genetically abnormal is going to have an implantation rate closer to 5 to 8%. A live birth rate is going to be possible, but you're still talking about only between 4 and 8%. So you're going back to the premise we did before in transferring a whole number of embryos, hoping that some will autocorrect. Yes, it is something that is possible, and I know that people have actually reported that. And in patients who actually have no other choice, that is something to consider. There are programs that will transfer abnormal embryos, but still, I don't want to actually leave the patient with that impression that that's something that is a go-to with a high chance of success. It's something that's possible if there are no other choices, but it's definitely not the thing that we look to as the recommended plan.
Yeah, just to add one more thing that, Dr. Deng is participants into a study where abnormal embryos are transferred. I know that you cannot talk about the study at this time, but maybe you can answer the question and give us the information about that study briefly before we go into the next patient. Thank you.
Yeah, I think like when people are talking about transfer of normal embryo, so when we are talking about abnormal, do you mean it's like a aneuploid embryo versus it's a mosaic?
Abnormal.
Or like, yeah, so versus it's a mosaic embryo.
Yeah.
I think there have been data actually showing that if it's like a diagnosed aneuploid embryo, the consistent and the patient and their study, they did the blastocyst like a stage biopsy. Then they took the rest of the embryo to do the genetic testing again. And there's a very high consistent rate between the biopsied specimen and the rest of the embryo. So which means if this embryo is diagnosed with aneuploid, then there's a high chance this embryo is abnormal. However, if it's diagnosed with mosaic embryo, then there's emergent data actually showing that depends on what's the level of the mosaicism. And it's a single chromosome involved, or it's like a multiple chromosome or like a complex chromosome like a mosaic, then it's associated with a different chance of a pregnancy rate and a live birth rate. But the data actually showing that transfer some of these like mosaic embryos, it could lead to live births, but there's a higher chance of miscarriage rate as well. So I think in your case, it has to be case by case. I highly recommend you have a genetic consultation and to look into what type of abnormality it was diagnosed and which chromosome is involved and what's a potential outcome if you get pregnant, and what's when I say outcome, it means like the neonatal outcome and pregnancy outcome as well, so that you can get an idea. But as Dr. Smikle said, if you have euploid embryo available, or if you have a resource to do another IVF cycle with the hope to create a normal embryo, that's always the I would say what the doctors would recommend. Stanford has a research, like a project going on, like a transfer of abnormal embryos. And if you're interested in, I can connect you with our research team and the genetic counselors and see what we can do to help you.
Thank you so much. let's take the next patient's question. Hello.
Hi, how are you?
Hi, how are you doing?
Okay. So I'll try to make my long story not too long, but so I'm 42 years old. I'm going to be 43 in June. I started fertility treatments when I was 40, like 40 and a half, I guess. And initially it was because I was told that my AMH was kind of already low for my age. At that point, it was 0.7. So I went to fertility treatment, did some testing, and right away it was a little confusing because it seemed like, you know, every time I was getting my AMH tested, it was kind of bouncing all over. It was 0.7. Then I was told it was 1.42, which they said actually wasn't that bad. So we did an IUI, then we did an IVF cycle, and I got 12 eggs. And essentially, though, it led down to having just one blast, but it was normal. So we froze it and then kind of went on to try to do, you know, subsequent cycles to see if we could bank any additional embryos. And then what I found was happening was I just wasn't able to get any to actually get to the blastocyst stage. I switched clinics because I was interested in maybe doing a fresh transfer, but then we still really just weren't having much luck at that point. I became pregnant once naturally, but that did not pan out, and it was kind of a long story there. But I had a miscarriage with that natural pregnancy. So just this past December, we transferred the one normal that we had frozen, and kind of tried to do everything possible to make it successful. I had fibroid and polyps removed, and saline looked great. We did an ERA, which said I needed a little extra progesterone. So we did it. My doctor kind of threw me on everything just in case, like baby aspirin and, you know, Benadryl and antibiotic and all different things. And we did have success at first. Embryo implanted, everything looked picture perfect, 6.5 weeks, saw the heartbeat. And then when we went back for our 8.5 week appointment, we were told that the baby had stopped growing and there wasn't a heartbeat anymore. So, you know, my doctor's basically saying at this point, she thinks it's due to egg quality and my age. Obviously, this was a normal embryo. So it's a little confusing, even though I know it's not 100%. But, you know, we're still trying to figure out. So at this point, I'm just trying to figure out at my age, you know, what's the best thing to do. I've been I just saw a hematologist just to check if there was anything with me from a blood work perspective, talked to somebody about immunology stuff to see. Everybody's telling me they don't think it's me. They think it's just the egg quality. The only thing we have left at this point is we do have 2 day 3 embryos frozen at another clinic. So I'm kind of just trying to decide, is it worth giving any more retrievals another shot? Do we transfer the 2 day 3s and just hope for the best? Do we move to donor egg? You know, I'm nervous now from having a normal embryo and still having it not work out. So we're just trying to figure out what our best step is, you know, since I'm going to be 43 in June.
Thank you so much. Dr. Smikle?
Thanks for sharing your information. And that's a heartbreaking story to get to that endpoint where you have that one euploid embryo and then do all you can to have it implant, feeling that there was success, and then having that peter out. The important thing we know is just that, you know, with even in terms of transferring normal embryos, they can miscarry as well. And we don't always know the reason. It may be that there is still mosaic syndrome in that what we consider a euploid embryo, and that may have contributed to things. But still, from what you described with having fibroids and having other things, there may be other factors as well that could be, you know, influencing things. As far as the decision in terms of doing the day 3 transfer or going to donor, I think the important part is to first look to see, you know, make sure you exhaust all your opportunity using your own eggs first, only because once you go to the donor, that route's closed. You're never going to have that opportunity again. Presuming that you're going to be successful, you're not going to then turn around at 45 and then try using your own eggs again. So that's important to kind of realize. As far as the success, it's going to be challenging to know without really knowing, you know, the rest of that information. And that would be my take.
Thank you so much, Dr. Smikle. Dr. Deng?
Yeah, I 100% agree with Dr. Smikle. I think your AMH 0.7 or 1.4 is actually not uncommon for age 42. That's within our expectation. You get 12 eggs and 1 euploid embryo. Actually, that's I would say very good in terms of like a 1 cycle outcome. Unfortunately, it led to the miscarriage, but we always say there's 10% chance of a miscarriage after euploid embryo transfer, because this chromosome or genetic component is not the only determining factor for like a successful pregnancy. I think, as Dr. Smikle said, if you want to use a donor egg, you can use a donor egg at any time, because I think after the transfer of embryo, after following the donor egg, the age would not like impact us that significantly or negatively. If you want to use a donor egg, you choose that at any time. But if you still want to try to use your own egg, I think if financially or physically, mentally, you want to try, I think it's not reasonable given the fact that last time you had the 12 eggs achieved. But of course, you want to optimize your medical situation. For example, I think you probably are working with hematology to make sure there's no antiphospholipid antibody, because you had 1 natural pregnancy loss and also with this IVF. And technically, we call like a recurrent pregnancy loss patient. And you want to make sure your thyroid function is normal, and just to check like I always say, when I see good number of eggs in advanced age women, I always want to make sure their testosterone level is good, their sex hormone binding globulin level is normal. You want to do the biopsy. So some people would recommend that you do endometrial biopsy, make sure there's no endometritis in the uterus. Kind of just optimize your situation before you try another IVF cycle. That would be my recommendation.
Yeah, we did do the biopsy when we did the ERA, and they said that was normal. Just to clarify, when I got the 12 eggs and the 1 normal, that was my very first cycle. So that was when I was 40. So now, you know, I don't know what my AMH is right now, but I am older. But I did just want to say, since you just brought it up, I did have a doctor back when I was 41, when I was kind of doing consults with other clinics, I had a doctor who ran what was essentially an immunology panel. And he did see my testosterone was a little high. My C-reactive protein was high. And the SHBG that you just mentioned was high. So my endocrinologist has me on metformin as kind of like a expected field. I never had really any other symptoms other than like at times excess hair and the testosterone being a little raised. But I mean, does that in and of itself impact egg quality too, having those numbers be higher?
Well,
sorry. No. You go ahead. Yeah.
I mean, with as women age, like there's the sex hormone binding globulin is gonna increase. Depends on how high it is. Sometimes if we see it's like abnormally high, that could be associated with lower testosterone level. When we say lower, it's like a free testosterone level. Total testosterone level usually is not gonna be accurately tell you the status of the testosterone level when you have high SB, sex hormone binding globulin. And there's data suggesting supplemented with a DHEA might help in those like kind of a situation, and to kind of like improve the number of follicles or eggs or embryo quality. That's something you probably can investigate, and sometimes the growth hormone can help potentially as well.
Okay.
Very good. Thank you so much for your question, and we wish you good luck.
Thank you.
Thank you. Now we're moving to the next patients. Hello? Patient number 4. Riley, if you can connect us to the patient.
Yes, I try to unmute them, but they're not responding.
So maybe once, while you're working on that, maybe we can take.
Can you hear me?
Very good. Hello, how are you doing?
Great, how are you?
Excellent. Thank you so much for coming to our program. Can you please proceed with your question?
Yes, thank you for having this forum to talk. But I am a African-American, about to be 46-year-old in June. I was diagnosed with stage 4 endometriosis probably in my mid-20s. And from then, I probably had 2 to 3 surgeries for removing scar tissue, cysts, fibroids, and my most recent surgery was back in 2015, and I had a fallopian tube removed. So I had the green light to go ahead and try IVF in 2016, and the implantation failed. So just now getting up enough nerve and want the desire to move forward, because of course I'm past that age, but I still want to try again. And of course I want to try with my own eggs. And the thing is that database is so limited to where that kind of have delayed me as well, because that database is so limited when you're looking for eggs. But I still mentally wasn't there yet to want to do that. So with that being said, I'm just trying to move forward, and currently I'm on supplements. I'm seeing a naturopathic doctor. She's went over my labs. My GYN is involved in acupuncture. So I'm doing a lot of the natural things, taking the supplements needed. However, I don't want to continue to do all of that when it's just the statistics are, well, I know the statistics are not there, but I know hope and I have that faith. So I just kind of want to know, moving forward, what would be my next step for a natural cycle?
Thank you so much. Dr. Smikle?
Thank you for sharing your story. And there's a lot of things that I would hear that basically, if you were coming to me, I'd probably want to say that I'd probably be not encouraging to be as pursuant using your own eggs. First, being diagnosed with endometriosis at such a young age, and realizing that endometriosis is an infiltrative disease that probably affected a lot of the ovaries and also causes scarring of the fallopian tubes. So that's what's impacted your process over the last 20 years. So going through and then trying to retrieve eggs and trying to get pregnant, especially at 46, it's going to be very hard for me to imagine that you may be successful. I'm not saying it's impossible because we're not gods, but at the same time, I'd say the chances in terms of being successful, in terms of getting a normal egg to transfer, is going to be really low. So therefore, considering going through as difficult as it is to consider getting pregnant using a donor egg may be a better opportunity, and that's something to consider. Still, I think that, you know, that's still not the only thing to look at, given the fact that you said you also had fibroids and you had the fallopian tube that was scarred. So before going through all and expending all the energy for that, I would want to make sure that your entire cavity is going to be normal now, to make sure it's receptive to whatever environment you're trying, only because that's probably going to be your best success in terms of doing things. If one fallopian tube was scarred and removed, it's likely that the other fallopian tube is impacted as well. So trying to do things naturally is probably also not likely to work. So it just leaves you very limited opportunities, and I understand that. But unfortunately, sometimes we're the bearers of bad news to say that there's not as many things that we can do and that we might take.
Thank you so much. Dr. Deng?
I 100% agree with Dr. Smikle. Yeah, I think a cavity evaluation is very important before you put your energy and money to like look for a donor egg or other resources. If you were still like trying to say carry the pregnancy by yourself at least.
Very good. Do you have any other question?
No, that would be all.
Fantastic. We're gonna take the last live question, and then maybe I have some other questions that we have received in the past, but let's move to the last question from a patient. Nipa, are you there? Riley, maybe you can work with Nipa to get her connected while we go for the next question. So my curiosity is, when you have patients in their 35 or under 35 and patients in their 42 or over 42, and they don't have any other conditions like endometriosis or PCOS or any other, alarming, condition, does the stimulation protocol vary depending on age? And I'll start with you, Dr. Deng.
Well, I think it's a great question. I think the stimulation protocol, it always, in my opinion, should always be like very individualized. Young patient, they could have a good ovarian reserve, but sometimes you could see young patient with a poor ovarian reserve or poor response. And age 40, 42, they could, I would say, agree, most of them would probably have AMH less than 1, but sometimes they could have a very good, like a number of antral follicle numbers. So I would say it's depends on, we should go case by case. And also when you talk about a protocol, you're talking about antagonist versus agonist, or it's like how much dose of FSH or GonoF or Menopur we should use. I think it depends on people's age, as you mentioned, but ovarian reserve is one major thing I would consider. For example, if a woman is age 42, MH less than 0.5, and antral follicle is only 3 to 4, then I might consider the minimal stimulation with antagonist instead of using like a Lupron long protocol, or use like 2 or 3 weeks birth control pills. Those which could potentially suppress her endogenous FSH and suppress her response. And for a younger patient, because of like a higher chance to get a good quality egg, I think most people would nowadays tend to use antagonist protocol. But also you want to use like a lowest dose as much as possible to avoid OHSS. Yes, age definitely will impact like the choose of the treatment protocol, but also depends on patients' individualized scenario.
Very good. A follow-up question for you, Dr. Smikle. This is a question that we received on the email. Agonist versus antagonist protocol at 42. Which one, obviously, would depend on the clinical manifestation and all that, but which one would you think would be more appropriate?
This is my own, there's data to suggest, but also what we do clinically in our practice. Because the goal is to get more eggs, then I'd say probably what we tend to do more than is the antagonist protocol, not trying to suppress the patient's endogenous hormone levels, because that's allowed us to get more eggs. And I think that's actually going to be the biggest factor. But it does, it all begins with where you're starting out, what the person's ovarian reserve, what's the patient's AMH, what's her antral count. That's what's going to drive the protocol more than anything else, because we're going to individualize what we do. But I'd still say it's unusual if we're going to consider even someone with a high AMH and a high antral count, if they're over 40, using a Lupron protocol. The risk of overstimulation is going to be much lower, which is always a concern. That's what we're actually looking for. But, they're going to need more eggs. That's going to be the biggest factor that we're actually looking at. Very good.
Let's take the question from Nipa. Nipa, are you there? Are you able to connect?
Yes, I am. Thank you. Thank you, doctor, for this forum and everything. I really appreciate all of your time. So my husband is also on the line and he's listening to our conversation and this whole forum. So thank you. So my question is, I started this IVF treatment at age 39, and we have been through 10 IVF cycles. We have done 2 IUI, and it's been, we do get some eggs, but most of the times when we fertilize, we don't make it to day 3 or day 5. At one time, about a year ago, we were able to successfully get up until day 3. And we did fresh transfer, and we got pregnant first time. And it was a first time transfer. We never transferred before because there were no embryo to transfer. So we did transfer at day 3 fresh. And I got pregnant. Everything was great. And around week 10, when we went for checkup, there was no heartbeat. So we had to go through surgery, and we wanted to know what was happening. So we also got a genetic testing done, and everything came out normal. So we don't know what happened. Our doctor did check to make sure there was no infection in my, I think, endometriosis lining. They did biopsy, and he said everything was good, but he still put me on antibiotics. So we are very confused at this point, and we don't know. I am 43. I will be 44 in October. Now when we go for IVF, we get about 4, on average 4 eggs. Antral follicles is about 5 on the left side. My right ovaries, I never get, maybe 1 or 2. And we have done acupuncture. We also went to go see immunology doctor, and they run the whole like 40 pages documents of the test, and everything was normal. They did put me on hydrochloroquine and metformin for 6 months. We are on a supplement. So our question is, should we still want a baby, and yes, we are open to last resort donor egg, but what can we do? I mean, at this age, at 43, should we still continue to have hope and go through IVF, IUI? Yeah, so this is where we are at.
Thank you so much. Dr. Deng?
Yeah, thank you for sharing all this information. You have been going through a lot, like 10 IVF cycles. I really appreciate your perseverance and like all these things you have done. So I just want you, like, I don't like have chance to review all these like IVF like treatment and outcomes. But you mentioned like those embryos, 10 cycles, it's hard to make to day 3 embryo. So I would say we know like most of the time, if the embryo has abnormal chromosomes, then high chance they cannot survive in vitro culture. But most of them will still make to day 3. When you mention about like when you don't have like a day 3 embryo, I would, that raise a concern. There might be some factors that are related to the egg quality of the sperm that would make the embryo not have this like a potential of a development. I think in those cases, you chose like a fresh transfer is I would say it's the right decision, because those embryos might not survive the in vitro culture, but can develop better in vivo. Unfortunately, 10 weeks you had a pregnancy loss. You said like it was genetically normal. I don't know, it's a female or this versus a male, like fetuses, because we know if it's a female, if a diagnosis is a female, 46XX, there could be potential contamination from a maternal cell as well. And unfortunately, nowadays, those whatever genetic testing we can offer can only test whatever we know. The technology has a limitation. We're not able to identify all those factors that can impact your fertility. But again, I would say 43, the chance to get pregnant with own eggs is, I would say, for each cycle, less than 10%. It's in single digits. Is that like worth to try? How many cycles do you have to try before you switch to donor egg? I don't think there's a good answer. You probably want to decide based on like your financial resources and how many cycles mentally, or like your family members, how much you want to go through. But also, I would say prior IVF cycle outcomes is one factor you want to consider. If at 10 cycles, you don't get like a good embryo on day 3 consistently, then the chance in the subsequent cycles with like a more advanced age could be potentially lower than prior. I don't want to discourage you, but I would say, yeah, if you want to try more cycles, it's completely reasonable. I think like it's obligated for me to provide my thoughts, and your physicians probably, you can review with your doctors as well, to just be aware of what could be a potential chance to get pregnant with IVF treatment. I don't know, Dr. Smikle, what's your thought? Yeah. I always feel it's a hard decision for patient and for physicians as well. I just feel like as a physician, sometimes I don't have that capability to guide or make that decision for the patient. I just feel like what I could do is provide the data, navigate you, and you can make the decision that you think is the right one for you.
I'd agree, but I'd ask one other question first, because we're making presumptions that the lab technology within the lab is consistent to what. So I'd actually also look to find out what's that lab's capability in other patients that age in terms of creating embryos and carrying them to a different potential. Because if you're in a lab that is actually not going to allow you to basically progress in that way, that may be a factor that might have contributed to the loss as well. I do agree that, within the first 3 days, male issues may actually factor in, and therefore that actually is where male potential is going to impact fertilization and also embryo development. After day 3, then it more relates to the egg. But, those are the factors that I would actually look at, because it's unfortunate that you went under these circumstances and then you got to that holy grail, you got pregnant and miscarried, and then had to make that terrible decision. But the unfortunate thing is that now time has passed by, and you've gotten through quite a bit, and then you're going through diminishing measures.
Very good. Thank you so
right.
much.
So thank you, doctors. My husband did get testing done from urologist, and they said things were okay on his end. My first 3 IVF was in Texas, and then my last 5 IVF, almost 6 IVF with 2 different clinics in Illinois. So when we had an IVF in Texas, I had 18 eggs and 11 fertilized, and only 1 made it to day 5, and that was abnormal. And then we had there was 2 other cycles that did make it to day 5, and we did genetic testing, and that was abnormal. So it's kind of mixed from everything, but anything that we can discuss with our doctor when we see them next time about the protocol, or if that would be insulting to ask them about the protocol, like to change or anything like that?
I would say that, I'd welcome somebody else's opinion in terms of, I'm trying to improve the potential for my patients. So I'm never going to actually not, be open to someone's suggestion. The unfortunate thing is that, as Dr. Deng said, other than trying to do day 2 or day 3 transfer, there's not a whole lot of hope you can try to achieve, because it does seem as if, you've changed labs, you've done different protocols, and we didn't quite talk about some of the protocols you went through. but it's a consistency that you're not making it beyond the day 3 stage. You're not getting beyond a point in embryo development. So it does mean that there is some impact that it has to do with influence of egg quality or egg capacity.
Yeah.
Okay.
Nipa, thank you so much for your question. We are getting close to the end of the webinar. I will give you guys a minute to introduce your practice, and with that, we will wrap up the webinar. I'll start with you, Dr. Deng, since you have to leave earlier.
Oh, okay. Thank you so much for having me. First of all, it's always a pleasure to join the webinar. I'm a reproductive endocrinology and infertility clinical fellow at Stanford. We at Stanford, our clinic is in Sunnyvale, and we provide all spectrum of fertility treatment to our patient, and including egg freezing, fertility preservation for cancer patient, transgender patient, infertility treatment, as well as third party treatment as well. And you can find more information from our website. And we're always here and happy to help.
Thank you so much, Dr. Smikle.
Thank you again for inviting us. Our clinic, Laura Fertility Care, is primarily in San Francisco, but we have offices in the Central Valley, in Fresno, and we're seeing patients. We provide a similar range of care, so women going through all forces of reproduction, and including fertility surgery if necessary. We do a lot of transgender, but also a lot of gay and lesbian care in terms of parenting. So we're here to provide anything that you may hopefully need to achieve your goal. And thank you for the opportunity to at least participate in the seminar.
Thank you so much. Well, with this, we're coming to the end of the webinar. And next Wednesday, we will have another topic on biopsy. The title is Biopsy or Not Biopsy, Where to Draw the Line. Thank you so much and have a great day. I'll see you next week.
Okay.
Thank you.
Thank you.
Thank you.
Bye-bye.
Bye-bye.